Hi, everybody. So I'm going to talk into this microphone, which seems a little silly given that we're all here in the room together, but we have some virtual participants, and so we need the mic so that they can hear us. And thank you for bearing with us for the technical difficulties. We're just setting up a couple things, and we have a virtual speaker here as well as our in-person speaker. So there's a little bit of coordination on that. But I'm really excited to introduce Danny and Inga, who have been participants in the consortium's training program for federally qualified community health centers, our climate action incubator. So they're going to present a little bit about community health centers roles in climate and health and the work that they've been doing both in the workshop and kind of generally how FQHCs fit into the broader climate and health movement. So I will let Inga and Dan take it away. And Inga, feel free to introduce yourself for our virtual participants. We'll be monitoring the chat as well. So just let us know if you have any issues, seeing or hearing anything, and we'll get right to it. Thanks so much.
Okay, so actually Danny's going to introduce me, so I'm going to let him do that. He's going to introduce both of us.
Perfect. Well, thank you all so much for being here today. I'm really sad I can't be there in person, but I'm tagging along with everyone else who is here virtually. So very excited to have the opportunity to share with you, learn with all of you. Before we get started, I just want to say if anyone has questions throughout the presentation, if you're virtual, please feel free to post that in the chat. We'll be monitoring it throughout and trying to respond throughout the presentation and also leave some time for questions at the end. So without further ado, as mentioned, I am Danny Lowe. I'm a family medicine physician at HealthPoint, which is a federally qualified community health center just south of Seattle. And I have the pleasure of co-presenting with Dr. Inga Robbins, who is a cardiologist at Atlanticare, a federally qualified community health center in Atlantic City in New Jersey. Next slide, please. So before we get into this, I don't know if the slides are working, but we'll try and get to the next one. I want to first just say that we have no conflicts of interest, but I do want to acknowledge, as Lucy just mentioned, that we are both part of the National Association of Community Health Centers and Medical Society Consortium of Climate Health Climate Incubator Program. So this is kind of akin to a fellowship, and we will be talking about it more during this presentation, as I think it's a really great opportunity for us to learn about what this is all about and an opportunity to collaborate and learn from each other doing this really important climate health work. Next slide, please. So our goals and objectives today are really fourfold. First off, we're hopeful that everyone here today by the end of this hour will really appreciate the role of outpatient health centers and in particular community health centers in addressing the issues of climate change and climate health. And we'll do that through a number of different ways. One of those, which is the second objective here, is that we'll learn more about what this Climate Health Incubator Hub really is. And that will hopefully allow us and inspire us to continue to collaborate across the country to use best practices and be able to implement different types of projects that maybe some of our colleagues elsewhere have used, and also appreciate some of the challenges that others have faced and how we might be able to incorporate that into our own work to have a more streamlined approach to our climate health work. In that manner, we want to do a little bit of a deep dive of a few different implementation projects that are already occurring or have occurred within the community health center space so that we can learn what does it actually look like. A lot of what we have talked about in climate health and climate justice has often been focused in the inpatient setting. So today is really focused in FQHCs. And then the last part of our presentation is we're really hoping to have an opportunity for all of you to talk to each other and really use some of the lessons that we talk about from the implementation examples at CHCs to develop some solution-oriented planning and thinking for your own health organization, regardless of where you are in your climate health journey, to be able to think about what is your next step to start doing more of this work. Next slide, please. So why focus on outpatient care? I think in the last 5, 10 years, we've made really tremendous progress in focusing on climate health in general, but much of this focus has been on inpatient care and what hospital systems can do to address climate health. And there is good reason for this. Among the clinical care that is contributing to climate change and the greenhouse gas emissions, the greatest percentage does come from hospital care. And that's why we've had some really important initiatives thinking about, how can we reduce anesthetic gases in the OR? Or how can we reduce meat consumption in the cafeteria when we are feeding thousands of people every day, whether it's our patients or family members, if we can have more environmentally friendly ways of providing food, that could really make an important impact. And this is also manifested in thoughts about infrastructure. So if your hospital system is in a region, for example, that's at risk of flooding, where are the generators in the hospital? If they are all in the basements and there's a major flood, are they actually going to be operable when patients come and need acute access and acute care? So that type of work is super, super important, and we need to continue doing it. But at the same time, over a quarter of greenhouse gas emissions from the healthcare sector are actually coming from outpatient settings. And so it would be remiss of us to just totally ignore this. If we truly want to become carbon neutral, we really need to be thinking about what can be done in the outpatient setting. And so that's what today's focus and our presentation is about. Next slide, please. And so I like to show this little pictorial, this graph at the beginning, because it kind of helps explain why that's still important on the outpatient setting as well. This is an internal audit from a US healthcare system looking at where different greenhouse gas emissions were coming from. And we don't need to get into the nitty-gritty of all the different color schemes here. The reason I show this is really just to highlight the three biggest bars. And you'll see in the bottom left, that kind of dark blue purplish are the scope 2 emissions from purchased electricity. The green is investments, where our healthcare systems put their financial portfolios. And then the big blue bar at the top is more scope 3, kind of purchase goods and services. And the reason I like to highlight this is that this is from a hospital system, and yet from an outpatient setting, those three bars are still the largest contributors to what we are doing. And so in that manner, the same solutions and problems that we need to address in hospitals are very similar thought process-wise to what we need to be doing on the outpatient setting as well. Next slide, please. So why community health centers in particular? I think, of course, I will acknowledge I'm biased here. I work at a community health center, but I think centering community health centers in this work is really instrumental. And the reason for that is when we think about the impact of climate change, both today and moving forward into the future, these aren't 1 or 2 time events. These are longitudinal changes that we need to make to mitigate the impact on our patients and our communities. And therefore, we need to be thinking about the longitudinal relationships and collaborations that we need to be making. So there's, of course, a really important role that acute care settings like hospitals are going to have. And when there's an extreme weather event and someone needs to be hospitalized, absolutely, we want them working on this. But really, if we're going to address climate change and the impact that it's having on our patients, we need to be thinking longitudinally, and where those relationships happen, they happen in our communities. And that's where many community health centers have been for decades and have developed longitudinal relationships with individuals, with patients, with families, with community leaders. And so thinking about those types of collaborations, I think, is really critical to this work and why community health centers should really be centered with it. The second thing is that this is frankly just where the people are. So more than 1 in 10 people in the US are patients of community health centers. And then when we start thinking about our more marginalized communities, that percentage goes up dramatically. So among those who are uninsured in the US, over 20% are CHC patients. The same is true for our rural residents. And among those who are living in poverty, over 1 in 3 are patients of community health centers. Next slide, please. And so when we think about that, we also need to think about climate health from the lens of healthcare equity. That our patients who are more marginalized and more often, therefore, are actually the patients of community health centers, they are the ones who are contributing less to climate change. They are emitting less greenhouse gases in general, and yet they face more of the impact and the burden of climate change. So when we think about these extreme weather events, if you are already housing unstable at baseline, you are much more likely to suffer from loss of property from these events. Food insecurity becomes a major concern. And when we think about other aspects of climate change as well, thinking about the summer and increasing temperatures, those who are living in poverty are at much higher rates of heat exhaustion and heat stroke. That's partially because they have less access to air conditioning. And we also see geographic mapping that shows that folks who are living in poverty are more likely to live in areas with less tree coverage, more cement, and experience greater heat as a result. This is similar to respiratory illnesses, where those who are in poverty and those who are in communities of color more often are living close to highways, close to airports, where the air quality is worse. And the results of that manifest in COPD exacerbations, asthma exacerbations. And so if we want to think about this through the lens of health equity, which I think is critically important, then we also need to center these patients, and therefore we need to center community health centers. So that's really kind of the context for why we think it's really important that CHCs are at the forefront of this work. And now I want to defer to my colleague, Dr. Robbins, to kind of go into a little bit more detail about what is actually happening at the CHC level then, what projects are going on, what sort of collaborations are occurring, and she's going to give us a little bit more insight to this climate health incubator hub, as well as some of those projects.
Okay, so is the volume good for, okay, perfect. Let me know if it starts to be hard to hear or see. Yeah, so I'm pleased to meet everyone here. And I think Danny has explained very well why community health centers are very, very important in the resiliency of our patient population. And so now, as we move on, I just want to mention that actually a lot of us at community health centers, a lot of the teams across the country, we come to this with a lot of humility. We never trained to be climate health advocates. We're like, how do we get started and how can we do this? So this is where this National Community Health Center and Medical Consortium Incubator Hub program has really helped us get started. And I know that when I started this work, it was with a few years ago, it was with a lot of concern, but also a lot of humility and a lot of questions like, what can I do and what is my leverage to make a difference? So this kind of program really has brought together 20 community health centers from across the country and given us the tools. So the educational components really connected us with what are the resources, and then we had the mentorship to help start our journey as leaders and also collaborate in groups. So our different participants have been put into different teams, and we've been mentored as we build our projects. So the goal of the project is for us to create a decarbonization and resiliency proposal to submit to our CEOs. And so there are a number, we have quite a spectrum of CEOs, CHCs. We have larger ones with 20 different locations. We have smaller community health centers, and we all have different needs, and we all have different barriers and different strengths. So that's why there's a whole wide variety of things that we've been mentored to do. So one of which could be environmental commitments, and we'll see what happens when when the teams at FQHCs start talking to each other about this topic. We're having teams that are formulating strategic plans, figuring out what is the strategy for putting our work into action. And then sustainability governance is what a lot of teams are interested in. How do we create teams that are going to make sure this work continues at our FQHC or community health center? And then we have the emissions audits, which are going to identify where are most of the emissions, where are the most meaningful targets for us to decarbonize. And then the solar and microgrid that we'll talk about a little bit more, commitments to ESG investments, and resiliency hubs. So one of the first centers, we're going to talk about 3 sort of deep dives into different projects that are being done in our health centers to give you some examples of what is the work that's going on. So we're going to talk about Harmony Health, and they contributed this information about their FQHC, which includes 3 locations. So they're kind of like a similar size maybe to my FQHC. And so they've got also a clinic on wheels and a street medicine team. And after fires and blackouts being in California, of course, they identified a critical need for resiliency, and they were able to install a microgrid. And again, they feel their mission to support community health is very important. So this is why they feel they want to expand on this. They need to do more. And so they want to weave sustainability into the culture of everything they do. And they are creating a sustainability committee. And this includes leadership, and it includes everyone across the team, from doctors to nutritionists to medical assistants. And they also have an AmeriCorps member helping them. So some of the priorities, consulting with the National Academy of Medicine map to find resources, reducing transportation-related emissions, so that's a very important contributor, waste audit and recycling, energy efficiency and weatherization, and patient education and resiliency, designing sustainability plan, and also an important part of scaling up to empower other FQHCs by sharing work. So a lot of these key components are really strong components for FQHCs to pursue. And so we actually sourced a number of different quotes from FQHCs because we're really here to share the work that all these programs are doing. And so I'm going to actually let people read these quotes on their own, and I'm just going to highlight a couple key themes. So here we asked a question: what inspired you to apply, and what challenges were you meeting? And so a lot of the responses, key themes here, were commitment to the community, and understanding that commitment to protect and serve involves addressing climate, and then resilience. But the other piece was, as a potential challenge, the how this program was going to help buy-in and commitment from leadership, that was a key piece. So then the next question is, what were the projects we were working on? And here again, serving the community, resiliency, key things here in these quotes that have been from our member programs. And then here are some of the takeaways. So these takeaways really resonated with me. And again, patience, time, creativity. So we come to this work with a lot of humility. But working in federally qualified health care centers, we're facing challenges every day that we don't know how to deal with, even before the climate crisis. So we do have patience, we do have creativity. So these are some assets that we bring. And then the next one especially resonates, surprised how responsive and ready our staff were to participate. Because a lot of times if you don't have the conversation, you think you're the only person who feels this way, then you start talking to other people at your FQHC and find out everyone has these same concerns, everyone has these same passions, and everyone wants to find a way to take action. Another key takeaway is that this program, it starts with getting your CEO to sign off saying that they are going to review the proposal. So that really gets the foot in the door, and that's how this program has really helped us get our foot in the door with this work. And again, conversations and being part of the community, that's really what gets the work going. So now I'm going to turn it back over to Danny to talk about his program.
Thank you, Dr. Robbins. And so I wanted to have a little bit of a deep dive for everyone because it's easy to see what some projects can be on the surface area, but sometimes it takes a little bit more time to understand what this looks like at the actual CHC level. Before I go into this, I do want to just call out and thank you, Emmy, for mentioning this in the chat too, that previous graphic that I had mentioned that showed the different scopes of emissions was from Practice Green Health and the NG Impact collaboration. I think the citation got cut off previously, but Practice Green Health is doing some amazing work with this. And so for those who are interested in kind of figuring out more of those internal audits and stuff as well for that, please reach out to folks there because it is so important for this work. In terms of one of the projects that we are working at HealthPoint, so that is where I work. It is a federally qualified community health center in South King County, just south of Seattle. And I want to provide a little bit of context for who we are first before talking about that specific project. We are actually a network of 20 clinics, so serving about 100,000 patients, and that includes school-based health centers as well as standalone clinics as well. And many of our clinics have their own internal pharmacies at the clinic site. And one of the issues that we wanted to address was to reduce the impact that metered dose inhalers were having on the climate. So for anyone who's not familiar with this as a topic, metered dose inhalers are actually the most commonly prescribed inhalers in the US. And the way they work is they use a propellant to help deliver medication to people's lungs. This is for anyone who might have asthma or COPD, for example. The challenge with these inhalers is that the propellant is actually made of hydrofluorocarbons, which are really, really potent greenhouse gases. They're actually 2,000 to 3,000 times more potent than carbon dioxide. And so what this ironically does is, as we're thinking of how do we treat someone with a respiratory illness, we give them this inhaler, and then them using that inhaler, they are actually directly contributing to the increased temperatures that we are having. And then that also can also be associated with poorer air quality. And then, of course, people in the future are suffering from more asthma exacerbations, COPD exacerbations again. So it's really this kind of perverse cycle that is occurring. And so we were thinking at HealthPoint, what could we do to try and address this? Next slide, please. So I want to first kind of give some broad strokes of what we were trying to do, and then I'm going to go into some of the more nitty-gritty details about the challenges that we faced. So this was our general idea, and we wanted to make sure there was actual buy-in for this project at first. So the first step was reaching out to other clinicians and pharmacists to say, hey, do you think this is a problem? Is this something you guys would be interested in tackling? And for us, this was actually the easiest step, that there was a lot of interest in this topically. And so Getting the ball rolling, not a problem. The next step, though, did require a little bit of work, both in terms of learning just the climate science of this, how much of an impact were meter dose inhalers? And then secondly, are there actually alternatives? And the reality, fortunately, is that there are. There are dry powdered inhalers that in most instances are just as efficacious as meter dose inhalers and can be used in place of them. This is commonly done actually throughout Europe. We then also wanted to see what's actually happening at HealthPoint. So we looked at all of our internal data from our own pharmacies and saw how many prescriptions over the past year were there for inhalers in general. How many of those prescriptions were actually then dispensed? And of those that were dispensed, how many of them were meter dose inhalers and how many were dry powdered inhalers? We then tried to take that to our entire clinician pool and pharmacists because we only had a small group of people really familiar with this initial data. So we got permission to present at our all provider meeting both the data that we found internally as well as the kind of climate science and the difference between meter dose inhalers and dry powder inhalers. And we are now ongoing in our work of trying to track, does this knowledge change practice? Are we seeing a decrease in inhaler prescriptions from MDIs and changing those to DPI inhalers? Next slide, please. So that's kind of the big picture, but there are some challenges that I want to talk about and go into detail about, because I think often some of the challenges we face in CHCs and sometimes even just across healthcare centers in general are quite generalizable. And so if we're able to use some of these examples, hopefully this will be something that others may be able to learn from and better expedite or streamline their process. So one of the first challenges we faced in this work was just getting leadership approval to present to our entire clinician workforce. Part of the problem for us is that we only have these all provider meetings twice a year. And so during these meetings, there's a lot of other really important clinical information that is being shared. There's lots of institution-specific information, workflows that are being shared. So to find that time, we had to create a pretty compelling case for our senior leadership team from the get-go. And one of the things that we did in this manner was as we were collecting this data, we actually were already putting in that request to our senior leadership team. And so one of the takeaways that I like to point out from this is that when we're doing this climate health work, it can be really valuable to actually be thinking 2 or 3 steps ahead if we are able to. So that if we're successful with the thing that we're working on right now, what would be the next step after that? And is that something that requires some pre-work so that if we get there, we're not stuck for 6 months now waiting for, in this case, the next all provider meeting. The second challenge that we ran into is that we may be able to discover that in most instances, dry powdered inhalers could be as efficacious as meter dose inhalers, but are they actually accessible to patients? So our clinic serves predominantly patients on Medicaid or those who are uninsured. And so one of the key areas here was to find out, are the dry powdered inhalers actually on the formulary for Medicaid in Washington state? So in Washington, our Medicaid system is called Apple Health, and it's very publicly available what drugs, what medications are on those preferred medication lists. And there were some examples of dry powdered inhalers that were already on that preferred list, but there were a number that were not. And so in those cases, it makes it really difficult to recommend a prescription for that when it's likely going to require a prior authorization, likely be rejected by the insurance in the first place. So what we did from there is we actually set up meetings with the Washington State Healthcare Authority and then met with their pharmacy team to kind of discuss this as an issue. And what was really surprising and quite pleasant is they were actually really receptive to this conceptually. They were not familiar with the climate health impacts of meter dose inhalers and yet had a separate team that was trying per the recommendation of the governor to address climate change in the healthcare sector. And so this was something that they were very responsive to. And since meeting with them, we've actually been able to add a couple of dry powdered inhalers to the formulary of preferred drugs on the Washington State Medicaid list. So this is something I also like to share out, just because every state has their own healthcare authority that's going to have different perspectives on this, but there are opportunities to meet with them. And sometimes this might not be, the reason they might not have it on formulary might not be, antagonistic. It might simply be because they're unaware of it. The next challenge that we are running into is just changing behaviors. So most of our clinicians have been practicing for a number of years and prescribing the same inhalers as they've always been trained to do. So to get a change in behavior can be really difficult. We're trying to do that with more and more education in multimodal ways. Some of that is just word of mouth. Some of that is ongoing presentations from a clinic by clinic perspective, trying to find champions at each clinic to do that. We're also trying to share this information more broadly beyond just HealthPoint. So we've written articles in our Washington Academy of Family Physician magazine to talk about this, in our county medical society magazines, to try and just increase the awareness of that issue. And the last thing is what this looks like, I would say, in the electronic health records. So when we started this work, we were with a EHR called NextGen. I don't know if others have worked with that or not, but it was a little bit challenging for us to really implement this really well with that. We have since changed to Epic. And when we are using Epic, we actually have the opportunity to develop smart links that can prompt a provider when they are prescribing an inhaler to basically ask these questions of, do you want to prescribe this, or do you want to prescribe a dry powder inhaler if they started with a metered dose inhaler? And it can actually link to someone's insurance to see if that's if it's within the formulary or not. And if it's someone who's uninsured, what the cost of that out of pocket might be for this inhaler versus that inhaler. So I know we often struggle with our electronic health records, and they can be a source of major frustration. But I think this is also an opportunity where we can use them to really further this climate health work, and can be really powerful. We're just trying to implement that right now at HealthPoint. So we're about to see, is that going to make an impact or not? But fingers crossed, and very hopeful for the opportunity that may present us. So now I want to offer it back to Dr. Robbins to share another kind of deep dive example at her site at Atlanticare.
Yeah, so before I go on, what is our expectation now for finishing at this point? Because I know the next one starts at 3:30, so we just want to make sure we're all on the same page, because we do have sort of an interactive part of this that we want to have time for.
Yeah, I think because the last session in the auditorium went a bit over, just take the time that you were planning for. We might cut the sharing activity by a few minutes just for time, but there's a break after this, so we could just go into the break a little bit, and then the next workshops will hopefully start at 3:30 after that. So does that sound okay?
So yeah, well, it is the afternoon. Is everyone up for going to like 3:10? Yes, I see thumbs up for that. Okay, all right. So again, emphasizing the diversity of the programs involved. Here you can see an image of our Atlantic City boardwalk. So Atlantic City is a very small, compact city that has had some hard times with casino closures, and we've had a lot of people out of work as that's evolved over the last 15 or more years. And then, of course, we got hit with Sandy, which was very devastating to our low-income population. And we are right in the heart of the city. So many of our patients actually arrive to our clinic on foot, and there's pretty good transportation. And we do have 3 main sites, 2 of which are in the heart of the city, with about a 15,000 patient panel. And of course, vaccines have to be transported off-site when we do experience power outages. So what were we thinking of? This is a picture of our our main site here. So what were we thinking of? Well, we were concerned to decarbonize. We don't want to be part of this problem. Resiliency for power outages. But also the idea, like, how do we grow and empower more people in community health centers to enter into this work, including our whole team, and how do people start the sustainability journey? Because I remember that it was very hard for me. And also to set the groundwork to sustain this. As you've seen, these are some of the priorities of other health centers as well. So what were the challenges? Well, you can well imagine the challenges. A spread thin by constant crises. We have experienced fires under the boardwalk. We have community health centers rescuing our unhoused population from under the boardwalk when extreme weather events occur. And we have a lot of community needs that our Rockstar team does the best they can to meet all the time, and it's never enough. So I definitely came at this with some trepidation, and then also, as I said before, out of our comfort zone, doing something different, something new. And so the other issue was, how do we identify which are the things that our team really cares about, which are the things that we want to prioritize, and how do we create a structure around that? And then obviously financial. So how do we identify the assets? Well, at this point, we're thinking, yikes, we better really reach to figure out anything that can help us. And clearly, this program has really been that support. And one of the things we learned about through the program was the charge partnership between the National Association of Community Health Centers and Collective Energy that will basically take some very basic information from you, and then they do all the footwork and all the assessments, and they help you get through the whole project. So we're in the process of finding out whether this is something that we can do, and they have been a great resource. And then again, the whole list of resources. So one of the resources that seemed like it's going to work well for us as part of our proposal to our CEO is My Green Doctor. And it turns out that we have free access to that because Medical Society of New Jersey is a member organization. And so some of the advocacy that we do across different spaces becomes very important. So what were some of the assets specific to us? Well, because we're small, we all know each other, we're a close-knit team, our CEO is more accessible, and we also have medical residents that need to do projects as part of their growth and part of their learning and are very concerned about sustainability. And we have a neighboring university that has a sustainability program, and we had never done any collaboration with them. So it was about cold calling, but we knew we were going to need help because we weren't going to do energy assessments on our own. There was like a lot of stuff that we really didn't have the bandwidth to do, as we mentioned. And then also meetings where we can share this work are exciting to our team to be able to connect in spaces of state community health center meetings and professional state meetings to share the work. So what was the biggest surprise? Well, I think the biggest surprise again is that, a lot of us were there thinking, we're really concerned about this, but not really having talked to anyone else that we worked with. And this program really spurred those conversations and made us realize, wow, a lot of people in our health center are really showing up with this. And again, we recognized a common passion that we didn't know was there. And that really gave us a lot of momentum. So again, with all the, humility and all the being out of the comfort zone, that kind of concern that people at community health centers, because what are we? I mean, we're basically mission-driven places that care about equity, that care about wellness, that care about protecting our patients. So this is why, even though we didn't talk about it, we all shared this concern, and it makes sense. So at this point, we decided we wanted to prioritize solar energy and energy efficiency and plastic reduction as part of our CEO proposal that we're designing for the project. We wanted to continue the lunch meetings, continue sharing ideas to build this proposal. And we also have brought on Stockton to do some of our energy efficiency assessments. So here you can see a picture of Dr. Hutchinson, one of the professors there, and Chris, one of the students in their energy lab at Stockton. So definitely finding out what resources are in the community that could help you if you have limited resources. So I wanted to, again, it takes a team. I wanted to thank the team at MyAppQHC, and I also wanted to really express our appreciation for this program, and also other members of my team. So one of whom is here now. If you could stand for a moment. Yeah. So now I'm going to turn it over to Danny, and we're gonna do an exercise for all of us. Some of us may not be working in community health centers, but we can bring this to whatever space that we're in.
Wonderful, excellent, perfect. So I know we're limited on time. In the next kind of 5 to 10 minutes, we have some questions for each of you to kind of reflect on personally. And then we're hopeful that we'll each meet in partners. So for those who are on Zoom, we will have small breakout rooms, and those in person, you can grab the person next to you. But to really think about where your health organization is in this climate journey. And with that, what might be the next steps for you? And so we've posted some questions here. Who are your allies? What are strategies to bring people together? So who might you want to do this work with? And what would be most important or meaningful for both patients and for staff? And then lastly, kind of thinking about what are those next steps in order to address the unique situation of your health center. Because you might be in a hospital system, you might be at an FQHC, you might be an independent center with IHS. All of that is fantastic. What is unique about your situation, and what would you need support kind of doing next? And then lastly, are there barriers that you are either already are experiencing or anticipate experiencing that you may need some help with? So we hope, thinking about these questions, each of us can take about 5 minutes to kind of self-reflect, thinking about what type of project or what next step might be most valuable for you at your health organization. And then we are going to chat with our partners, and we will ask or invite folks who want to share some of their ideas, something they learned from their partner, from their own self-reflection, to share with the group. So thank you. We also have time for some questions there at the end. For those who are on Zoom, you should be broken out into a group here in just a moment by Lucy. And I believe it's 2:58, and so in about 7 or 8 minutes, we will come back to join the larger group. And if you are in person, please feel free to start jotting down some notes and then turning to the person next to you to collaborate with.
Anybody has conversation on any kind of conversation is wonderful, but if there's a conversation about these talking points that you had with your partner that you would like to share, if you could raise your hand, and we would be very grateful. Okay. All right.
Good afternoon. Thank you. We were discussing here, and I raised a question that one of my primary reasons to come in here.
Hold on, we're going to pass the mic to you so the
like microphones. I can
whoever to participate.
That's okay. Here. That's okay. Thank you. Hi. So we were just discussing about the current environment related to the socio-political environment, right? And one of the questions I raised, and one of the reasons I actually joined to this pamphlet here today was I was want to hear what are the HQAZs are doing with the constant challenges related to the executive orders, and particularly because a lot of the funding that comes to the HQAZs are from HRSA, Medicaid, Medicare, etc., which is federal money. And then how do we doing or continue to build on all these great ideas and strategies and approaches that you guys actually share here without getting the risk of losing critical funding for the communities?
Yeah, that's a great question, and let me try to answer it. So again, here again, with humility and resilience is the short answer. But yeah, so I think at some point we're still trying to figure out exactly where things are going to land, of course. So off base with all that uncertainty, I think this is a very, it's never been more important to make our voices heard. I'll be up on the Hill on Tuesday, and really to talk about the IRA. But we've also been up on the Hill to talk about Medicaid earlier in February. So, we're not going anywhere. I mean, one of the things that has been resilience for me in dealing with everything that's happened is, looking around, we're all here and we're all still growing. So I know that there's a lot of uncertainty, so I'm not giving you a lot of specific answers. So maybe I can, yeah.
I'm happy to chime in a little bit here too, and I, like Inga, am going to take this from certainly a place of humility and say this is a challenge, and we don't have clear answers right now. That's for sure. I think one of the things that we've talked about a lot in this Climate Incubator Hub, and it's been really valuable, we've had a number of folks, and we have folks across the political spectrum from where their clinics are. So people in very red states, people in purple states, people in blue states. And one of the things that we talk about is just the language we use about this work. So of course, at this conference, we are freely talking about climate change, climate health, etc. In certain settings, that sort of language may not be the appropriate language to be using. And simply talking about resiliency from an economic standpoint, from other perspectives, can be really helpful. So when we are thinking about, extreme weather events that can cause challenges, those are economic challenges to patients. When we think about trying to reduce our greenhouse gas emissions, we're obviously doing that from a climate conscious manner, But we also have to think as organizations not only to not lose federal funding, but even just longitudinally, if we can be more cost effective with solar panels or microgrids, EV stations, all these things, this all of a sudden becomes an economic conversation rather than just a climate conversation. And so I think the way that FQHCs, many of us are thinking about this is not to change the work that we are doing per se, but depending on our audience and the sphere that we are working, is to think about the language that we use for the rationale of why this is so important and why we're doing it. And so that may mean, if it is necessary, removing words like climate change or climate health, and yet continuing the work itself. I think there are spaces and other leaders who will say, we need to use that language. We don't want to back away from it because that is the truth and what's going on. I think that's up for debate, and leaders at different FQHCs are making different decisions about that. But I think that is something that we are trying to navigate as we go. So that would be my 2 cents. I wish I could give a more inspiring answer to that, but yeah, that's kind of what I have for the time being. It sounds like there might be someone else getting a message in the chat who wants to speak to this as well, because it's such an excellent question.
Dr. Lowe, thank you so much. Your comments were spot on. I'm Ben Money, I'm Senior Vice President of Population Health at NAC, the National Association of Community Health Centers. And, as mentioned, we are, like most human service organizations, facing the challenges of executive orders and, congressional budget resolution that is still not been addressed. We also have our pharmacy discount program, 340B, under attack. And, we also are looking at, potential changes with the Medicaid program, which is really the lifeblood of community health centers. And so we've got this federal horizon that is very challenging. But, in terms of what's happening to our patients, they get hit first and worst by the effects of climate change. And within health center statute, I'm going to talk about this a little bit more in the afternoon session, we have a mandate to address the air and water quality and prevent our patients from being exposed to toxins. That's in our statute. And so that's part of the work that we do. So the work needs to maintain. Will we need to adjust the language? But we're still going to persist in the work.
Thanks, everyone. Those are some good answers. I just wanted to also say, hi, I'm Jess Henshaw of the National Association of Community Health Centers. And if anyone is having any specific concerns, not saying that I can help address all of them, but if you are having concerns, especially about federal funding for climate initiatives, feel free to email me. My email is Hinshaw, HINSHAW @NACHC.org. And sorry, I can connect after, but yeah, if you have any specific questions, we have just an amazing community here. We have Migrant Clinicians Network, we have Americares, we have MSCCH, we have so many great partners who are working at the federal level. So if you have a question or specific concern, we can probably connect you to the right people. We're also connected with Lawyers for Good Government, to the Environmental Protection Network, who are also very specifically looking at what's happening to the funding for climate change initiatives at the federal level. So feel free to reach out and we can try to connect you to the right people, do our best, right? And then of course, MSCCH has these amazing state level groups that you can get connected to and engage possibly in state level advocacy if that makes sense for your organization.
All right, so we want to thank everybody so much for joining us and for all the great comments. And I'm going to be up front for a little while if anybody wants to ask questions now that we're wrapping up.